Hey, this is Michael Schick at Sono Stuff. Thanks for tuning in. This lecture is all about point-of-care ultrasound in CPR. I was inspired by a great talk that I saw at AIUM, and it is harder than you think to not do harm with ultrasound during these critical patients like coming in cardiac arrest. So let's talk about what we can do with ultrasound that might actually help our patients and make sure we're not doing harm. So when you think about a patient coming in and they're under CPR, what is really going to help that patient? It is high quality CPR. We want to maintain their coronary perfusion pressures because we know that is the greatest chance to have return of spontaneous circulation. We also want to maintain their cerebral perfusion pressures because we want good neurologic outcomes. Now, how about other things? Drugs, epi, things like that. Yeah, maybe they help. Ultrasound, again, maybe it helps. When we think about how we use ultrasound typically in these CPR patients, we think about reversible causes. The patients may be in PEA arrest, severe hypotension, and we really all want to find the giant pericardial effusion and tamponade so we can stick a needle in it, fix the patient, and we come out looking like a hero. But this just doesn't happen that often. And it is worth looking. I'm not saying it's not worth looking, but it just doesn't happen that often. Again, other things we can look for that might reverse PA arrest would be pneumothorax in case they have a tension pneumothorax. We may want to look in their abdomen because they have a ruptured AAA or ectopic pregnancy that could be leading to severe hypotension and cardiac arrest. And we may want to look for heart strain or a DVT in the case that they have a large pulmonary embolism. Now, it may not be a new concept to you that we are not very good at checking the pulse when we're stopping CPR and seeing if we have return of spontaneous circulation. We just have adrenaline, the patient may have really low blood pressure, and we're just not very good at this. So some people put arterial lines in, some folks use the ultrasound to see if there's blood flow moving there, but we're not good at it. And the other thing that we're doing is we're looking at the rhythm strip. We want to know what rhythm do they have, because cardioversion is another thing that can really help these patients. Early cardioversion, get them out of that bad rhythm, VFib, VTAC, and into a perfusable rhythm. But the newer concept I want to introduce is that we might be looking at the rhythm strip and interpret it as PEA. But they may not be in PEA. They may be in what some people call pseudo-PEA. It's just that the blood pressure is so low, it looks like a perfusable rhythm, but we cannot palpate the pulse. The other thing that does happen sometimes is we interpret the rhythm as asystole, but it could be fine ventricular fibrillation. So I submit to you that another way we can really help with ultrasound is identifying rhythms like ventricular fibrillation that we may have not found otherwise, shocking them out of it, and turning that into a perfusable rhythm. Also identifying pseudo-PEA, or just patients have really low blood pressure, and trying to treat that underlying cause, or at least helping that guide us in our resuscitation. And so that when we're calling things cardiac standstill and declaring the patient dead, we're really making the correct interpretation. So check out this patient here. If you look at the heart, you may immediately think this is cardiac standstill, and we're looking at peristernal long axis here. But if you really look carefully at these portions of the left ventricle and the interventricular septum, you can see there is fine movement, and this patient, in fact, has fine ventricular fibrillation. Another example here, we have the left ventricle here, left atrium here. You can see the mitral valve. It is fluttering up and down, up and down, up and down. And valve movement in itself can be cardiac standstill. You may have no ejection fraction, even though the valve is moving a little bit. But here along the muscle, you can really see that fine movement that, again, is ventricular fibrillation. This patient has a really rapid rhythm. And you look at the left ventricle here in the peristernal long view, aortic valve and mitral valve here. These are challenging views, but you can still see that there's opening here of the valve and that there is organized movement of the heart. This is a patient that actually had ventricular tachycardia, so not VFib, but still a shockable rhythm we need to get the patient out of. And I hope you're seeing that ultrasound can be very sensitive to identify these arrhythmias. Now let's compare that to cardiac standstill. In this subxiphoid view, the left heart, it's just not contracting at all. You see the bubbles from the IV fluid that the patient's been given just swirling around in the right heart, really not going anywhere. Don't even see much valve movement at all. So this is a pretty clear cardiac standstill. Compare that to this heart, another subxiphoid view. And we have some organized movement now. You can see sort of quivering of the heart. This is a patient that they said had PEA, but you can see that there's actually organized movement, even though very little is coming out of the right heart. But this is someone that probably had pseudo-PEA or just very low blood pressure, couldn't feel the pulse. Another example, subxiphoid view, liver's here, heart's here, and this is the left ventricle, here's the right ventricle, and just this is cardiac standstill. No movement of the heart at all. Another subxiphoid view is the liver, left heart here, right heart here, swirling of these bubbles again in the right heart. Now you can see some movement of the aortic valve and the mitral valve. And I know there's not going to be 100% agreement here between physicians, but this really looks like cardiac standstill as well. Hard to get any movement, any organized movement that I can see out of the left or right ventricle. And so this patient I would probably call cardiac standstill, but these are trickier cases. Now this patient looked kind of similar to the last one. You can see a little movement of the tricuspid valve and the mitral valve. The difference here is that when I look at the muscle, I can see this quivering of the muscle. Now the question is it organized enough not to be called cardiac arrest? And I would call this pseudo-PEA. Probably it looked like PA on the monitor, but when they gave the patient a little epinephrine, then this is what they found next. And now we have a little bit better cardiac movements. Definitely is organized. There's actually blood flow moving between the valves. Not much, but it is organized. And this is just an example of a patient that got ROSC, return of spontaneous circulation. So this is a heart that was arrested. There was no movement, and then they were able to do high-quality CPR. They gave medications, all those things, and now the ejection fraction actually looks pretty good from this heart. Now here's a patient that was diagnosed with cardiac arrest, and clearly they have very low ejection fraction, very little blood moving between the heart here. It's an apical four chamber, so this is the right ventricle, left atrium, and mitral valve here. This is the aortic valve. But you can really see that there's sort of quivering of this left ventricle, and I was looking at this wondering if it was ventricular fibrillation or maybe just this pseudo-PEA where we have organized movement but just a really low pressure. And at the end of the clip, I see the valve moving, I think in an organized fashion, so I think this is a case of pseudo-PEA. Now this patient, unfortunately, the next clip that they got at the next pulse check shows cardiac standstill. And here, same left ventricle, but not moving at all. Valve not opening at all. And you have this sort of swirling of bubbles and fluid inside the right heart. Two more quick cases here. Here's a peristernal long view. Left ventricle, left atrium is a mitral valve. Aortic outflow tract here, and this is the right ventricle. And patient came in with cardiac arrest. But you can see in the ultrasound, there's clearly some sort of organized movement of the heart. Patient's bradycardic, it looks like, and the ejection fraction doesn't look good, but there's contraction of the left ventricle and then opening of that mitral valve. So this is someone that I would resuscitate aggressively. One more case of perhaps pseudo-PEA. Patient has a pericardial effusion here, not one that's necessarily causing tamponade, but you can see that there is organized movement when the left ventricle contracts. There's some opening of the mitral valve. So again, this is not a patient that has cardiac standstill, but they have some organized rhythm and should be resuscitated. So now that I hopefully have you convinced that there's other things you can do with the ultrasound that may be important during a resuscitation in CPR, let's talk about our main goals of what we should be doing during CPR and how ultrasound cannot cause additional harm to the patient. So remember, our main goal is high quality CPR until we get a perfusible rhythm and maybe cardioversion, and we want to limit interruptions to CPR. We want high quality CPR. We want to reduce the time as much as possible between the interruptions. Generally, we have 10 seconds to do a pulse check. And that's the amount of time you should limit your scans to. The problem is that when we introduce ultrasound, we have studies now, both on the East Coast and West Coast and academic centers that say just ultrasound increases the time between pulse checks by about 8 seconds. So now we're not just 10 seconds, we're 18 seconds. Now that's a big deal. 1 second of extra time during these pulse checks probably incurs a mortality around 3% per second. So what can we do as resuscitationists and sonographers that want to do the best thing for the patient? We need to not do harm with ultrasound. So here's a patient getting CPR, ultrasound's on. The first rule here is don't interrupt CPR to do the ultrasound. You have a 10-second window, keep it at that. We don't want to do harm with ultrasound. Now, this is a subxiphoid view, liver's on top, I can see the heart below. I don't think they have a large pericardial effusion, but it's hard to get any other useful information from this. So during the pulse check, we can use ultrasound as long as we're not going over that 10-second window. Now, there are tips from the literature that will help us do that. So first, if you're an expert, you can shave at least a second off the time of doing the ultrasound and interpreting. So that just means the novice, the intern that's just learning how to do ultrasound, they're not the best person to do this during a CPR resuscitation. You should have the most trained person doing it. If you're fellowship trained, it probably shaves another second or two off based on the literature as well. So if someone's available that's done a fellowship in ultrasound, have them do it and teach the novice. If you have a dedicated sonographer, like a person who has ultrasound, is plugged in, is ready to go, there's gel on it, they've already scanned the patient a little bit so they know what the windows are and where they're going to go, then that's going to shave another second or two off the time. If you record the clip and you don't worry about interpretation while you're gathering the images, then you can interpret those after CPR has resumed, and that'll shave another second off. This all gets you down to about 13 seconds, still over that time of 10 seconds we want to hit. So these are just tips, but you still got to limit yourself to that 10-second window. Another important thing that came out is that if the leader of the resuscitation is the one doing the scanning, it adds time. So you should have division of labor. The person who is running resuscitation should not also be doing the ultrasound unless there is no one else. So one way to reduce by the whole 8 seconds would be to get transesophageal echo. Now there are barriers here. You have to be trained, you have to get the equipment, but there's a lot of advantages as well. That's for another lecture. So in summary, ultrasound, it has its place in resuscitation, especially in patients who are sick, and that includes patients who are under CPR. You can find some reversible causes. You can also look at rhythms in a different way and perhaps in more sensitivity than the rhythm strip itself. But you have to know what you're looking at, and you want to not interrupt CPR because we want to do no harm with ultrasound. We just want to do good by our patients.